groin complication is not fatal complication, but it is very annoying and common complication. So try to reduce the groin complication. We are using the vascular sonogram when you do femoral vein puncture, and you can differentiate which one is femoral artery and which one is femoral vein by compressing your groin, the patient's groin area with probe. If it is compressible, that is definitely femoral vein. So try to inject local anesthesia and insert the broken puncture needle to that directing to the femoral vein. It's quite easy. So we are using two venous puncture and use 14 French tripod sheaths and the other puncture for the transeptal long sheaths. So just two puncture is our standard ablation access. We are using 14 French tripod sheaths. You can put 3 mapping catheters through this sheath. So that's why that we are using just 2 puncture. But to make sure this sheath is very tough, especially dilated very tough. So make an incision and push the sheath gently and slowly. And when you push the sheath, you can try to move a guide wire freely and check it repeatedly. If guide wire is bent, you can move this guide wire freely. That means your sheath may damp to the venous wall. If you push more, probably you will make a disaster. The AF catheter ablation, probably the fellow's most difficult first hurdle might be how to put this duodecapolar catheter inside of coronary sinus. This catheter is 24 and deflectable. So if you rotate the handle clockwise, the catheter make a curve. This catheter is very useful to map the coronary sinus, also the right atrial free wall altogether. Also, you can deliver cardioversion energy with this electrode. But the difficult part is how to put this tip of the catheter inside the coronary sinus. So I would like to give you my tip. First of all, you can move catheter to the right atrium first, and then try to make a curve, and make a full curve, and push in, push in, push in. So make this position, like this position. But depending on the catheter tip position, sometimes you can luckily engage coronary sinus, but sometimes not. So make a figure 9 position in LAO first. That is first tip. And second step is make RAO view. And then catheter might stay like this. If in RAO view, catheter position is like this, if you push catheter, you cannot engage the CS. If this position, your catheter will move to the right ventricle. So if your catheter is here like this, how can you move to anteriorly? And in this time, if you rotate your catheter counterclockwise gently, your tip of catheter move to CS. If it is in this position, opposite direction, counterclockwise stroke, and you can engage CS. So you can estimate the location of coronary sinus in the RAO view, and then back to the LAO view, and gently push the catheter slowly. And if you feel your catheter is engaged the proximal coronary sinus, open the curve slightly and push more. And probably you can get the CS very safely and easily. Okay, that is the duodeca catheter position maneuvering tips. You can push the duodecapolar catheter into the IVC. You can just follow the previous catheter and guide wire. And in LAO view, direct your catheter tip the right atrial free wall side and make a full deflect down and counterclockwise torque. Make a figure 9 position in LAO view like this. And luckily, our catheter already put inside of the coronary sinus, and gently push little by little, and you can check the catheter position proper or not in aerial view. And you can imagine the groin sinus location in the aerial view. You can make sure that the CS position by the distance between vertebral body anterior aspect to the groin sinus ostial area.